and we ask that you post questions to the chat box. Please mute your phone so that we can eliminate any extra noise. I am Carrie Wyrick, Director of Community and Adult Residential Services, NetCare Access, Columbus, Ohio. NetCare has been operating an adult crisis stabilization unit and crisis residential home and providing crisis services for Franklin County, Ohio since 1996. I'm glad you're joining us. The Crisis Residential Association is a gathering of individuals and institutions who are involved in crisis residential care. We find that since we're the only crisis providers in our regional areas, we can feel isolated from others in different parts of the country who are doing the same kind of work that we do. We decided we wanted to create an ongoing association, and in so doing, we advocate for comprehensive, dignified, and financially sustainable services for those experiencing a mental health crisis. Membership for the newly formed Crisis Residential Association is opening in May. Membership benefits include discounted conference registration, free webinars on relevant topics, networking opportunities with peers, and access to a national listserv of 200+ providers. Discounted rates for full-time students and people with lived experience will be offered. Next slide. Our next conference will be on October 3rd and 4th in Grand Rapids, Michigan, so save the date. Next slide. Now I would like to introduce Dr. Chuck Browning from RI International. I think you'll really enjoy his presentation. If you're familiar with Zero Suicide and are enacting its principles at your crisis residential program, or if you're new to Zero Suicide, I think you'll find his presentation very interesting and informative. Dr. Charles Chuck Browning is the Chief Medical Officer of RI International. He has devoted his career to improving the systems and care experience for mental health needs. He has held leadership positions in public and private systems of care, including crisis, assertive community treatment, rural community behavioral health, and opioid treatment. Dr. Browning graduated from North Carolina State, University of North Carolina Chapel Hill Medical School, and completed his internship and residency at University of North Carolina. Dr. Browning has also practiced in NC prison psychiatric systems and his own private practice. He has special interests in promoting several thought leadership initiatives in collaboration with RI International, including Crisis Now, Zero Suicide, Peer 2.0, and the Fusion Model. Dr. Browning grew up in North Carolina playing high school football for his father and then at NCSU, where he learned hard work and the importance of teamwork. He most enjoys spending time with his wife, Angie, and their 2 sons. Chuck?
Thank you, Carrie,
Take it away.
for the introduction. Thank you for the introduction. I'm really looking forward to talking about this information about Zero Suicide and as it pertains to crisis systems. I'd like to share, for some reason, there we go. So I'd like to share an initial paragraph from the Zero Suicide website that describes what is Zero Suicide. The foundational belief of Zero Suicide is that suicide deaths for individuals under the care of health and behavioral health care systems are preventable. That Zero Suicide is a combination of an aspirational challenge and a practical framework or tools for system-wide transformation towards safer suicide care. So I'd like to tell you a little bit about Zero Suicide by sharing another story of a different organization that underwent major changes for better safety outcomes. Aviation. So if I can take you back to December 29th, 1972, 23:42 Eastern Standard Time, Eastern Airlines Lockheed L1011 crashed into the Florida Everglades. At the time, the aircraft had only had a minor technical failure. There was a blown bulb in one of the displays. The crew all had their heads down, trying to fix the problem while the plane was on autopilot. And even though an alarm sounded to let them know that the autopilot had disconnected, no one had paid attention or was aware of that alarm, and the plane actually crashed. It was a preventable accident that was related much more to human error than any problem with the plane not being able to fly or stay in the air. So meanwhile, at the same time this is going on, other accidents are happening in the airline industry that typically highlighted problems with examples of captains doing all of the work while other crew members remained unoccupied, multiple different personalities clashing in teamwork operations, pushing down fear of being able to speak up and say, I'm concerned about this problem, or how to work together on error checking systems. At the same time that the safety and integrity of the manufacturing process of airplanes was improving, it pretty much left the main error to be dealt with as human error. Now, human error, not very simple to categorize as just human error. It is a much more complex with multiple factors, including things like environment, design, procedures, and training. So in the initiatives of quality improvement of this issue, because it was pretty significant at that time, they started developing multiple different ways to try to approach these different complex factors of human error. One of the things that happened was something called human engineering, where they helped change design of tools to be more crew-friendly, and therefore have the tools themselves decrease error through different quality improvement measures and measuring outcomes about that. In the 70s, though, there became a new term called crew resource management programs that were designed based on psychology to involve changing culture. So the entire crew became more focused on safety culture, teamwork, decision-making, training together, improving communication skills, letting anyone have the ability on the crew to be able to speak up and raise a concern of problems, development of very rehearsed standard operating procedures and systems with checklists. And the design of these was to catch errors, avoid errors, first avoid errors, then catch errors if they did happen, and then make sure you minimize the consequences of the errors if they do occur. The results are, over the past 50 years, been a sharp decrease in accidents. Going back in the 70s, having as high as 5 accidents per million departures, decreased now currently to 0.35 per million departures. I will be one of those departures tonight, so I'm very thankful for the changes in the culture of safety in this field. And these concepts have been used in a wide range of safety critical areas in other industries, such as nuclear sites, oil and gas industries, and also surgery especially has been an area in healthcare that's really focused in on some of those same principles and had successes in improving safety outcomes. So you'll find these same principles that I described very well correlated in the Zero Suicide principles, philosophy, and the tools that they share. I'd like to show this video that's made on the Zero Suicide website. I think it's a great example of capturing in a quick summary what can be done.
Every minute of every day, suicide impacts the lives of hundreds of people across the globe. It robs families of loved ones, young people of their future, workplaces of colleagues, and communities of their most valuable resource, their people. And surprisingly, of the 800,000 people a year worldwide who die of suicide, most saw a healthcare professional in the year prior to their death. Contrary to popular belief, the problem isn't that those at risk are disconnected from healthcare. It's that gaps exist that allow these individuals to slip through. Despite this, healthcare has remained unchanged, presuming many deaths were tragically inevitable. Inspired by the Henry Ford Health System in Detroit, Zero Suicide is a call to action based on the belief that no suicide is fated. It all starts with zero because a radical and systematic approach to perfection is the only way to create dramatic change, and it must be driven by leadership's commitment to creating a new culture around suicide prevention. 3 specific evidence-based interventions have emerged as central to Zero Suicide, creating the multi-layered approach that helps ensure no one slips through the cracks. First, we must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk at all patient touchpoints within a health system. Simple screening questions like, Do you have thoughts that you'd be better off dead or hurting yourself? Allows healthcare professionals to start a conversation about suicide, create a connection, and acknowledge the anguish and pain. The simple act of asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a future heart attack. Second, the strongest resource in preventing suicide is always the person at risk. By collaboratively designing safety crisis plans that include reducing access to lethal means and following up with phone calls after discharge, one recent study showed a 45% reduction in suicidal behavior. And third, we must treat suicide directly. We've assumed that treating mental health and/or addiction will fix suicide risk, but that doesn't always remedy the pain that underlies thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment, as well as caring and supportive contact, either between appointments or as close-care follow-up in the weeks and months to come. This relentless pursuit of perfection and insistence on evidence-based intervention works. Henry Ford saw a dramatic 80% reduction in suicide and maintained that success over a decade, including 1 year when they actually achieved zero. And at Nashville-based Centerstone, one of the largest nonprofit community mental health programs in the U.S., they reported a 64% reduction in suicide deaths since implementing these initiatives. And on the other side of the world, Gold Coast Health in Queensland has succeeded by utilizing the resources of the Suicide Prevention Resource Center, including a specific toolkit with its best practices and resources for data collection and continuous quality improvement. Additionally, thousands of other organizations around the world are now taking their first steps towards zero suicide. Bold visions have put a man on the moon and cured polio. For suicide prevention, there's no more time for half measures and missed opportunities. Only with insightful leadership committed to the pursuit of zero suicide will we be able to make significant strides towards eradicating these tragedies. Zero suicide. Healthcare that believes no one should die alone and in despair.
Yeah, I hear you.
Whoops, let me hit that mute. So our takeaways from the Zero Suicide video and the principles that I hope to share today as it relates to crisis really fall around those three main key points. The problem is we're having 800,000 annual worldwide suicide deaths, with 80% of those folks actually seeing a healthcare professional in the year prior to their death. In crisis settings, no matter what type of service we offer, and I know that this group has a great variety of different types of services. You can have different types of staffing patterns, locked versus unlocked units, residential settings versus more of a medical hospital model. We can all agree that we come into contact with those at higher risk of suicide than the general population. And Zero Suicide is a call to action for all of us based on the belief that suicide is not fated. And it also gives us the tools and the framework that is supported by evidence to help achieve that aim. So the first key phase shown in that video that I'm going to describe is talking about screening assessment. Number one, what we know about suicide is that we have to make it okay to talk about suicide and to screen for those things. If I present to my primary care doctor at a certain age range with a family history of cardiac disease, I am probably definitely going to get some type of screening tools, and they're going to start checking my cholesterol, things like that. That would be standard of care. If I presented to an emergency department with chest pain, there's going to be standards that basically help align the type of treatment that I'll receive that would be universal across the country. However, if you have suicidal ideation, there is no guarantee that those are the things that you're going to come into contact with. And yet, if we ask about suicide risk, it is more predictive of future suicide than cholesterol scores are for a future heart attack. I have a friend, Scott. I'm going to tell you a story about him. This was actually a week ago. In one more week, it will be an entire year since this happened. Met him through a high school friend who's friends with my wife and I from high school. She was coming home from a girls' trip on a Sunday morning, called in tears, very upset that her husband, Scott, had called her and said, I am just really struggling with suicidal thoughts. I'm having thoughts of wanting to get a gun and harm myself. And this was out of the blue. This was not something that was characteristic with him or had ever been a historical thing to happen. He actually had been to see his primary care doctor a few weeks before and had dealt with depression, but never suicidality before. And they had started some new changes in medications. The long story short, in talking with him, he did get connected to appropriate care and had a really good outcome. However, at the same time that this was happening, we talked to him about his primary care experience, and although they talked about medications and making changes, there was never once questions about suicide or suicide risk. And we know that this happens quite a bit across the country. So one of the things as you're thinking about how you operate things in your crisis system is what kind of tools do you have in place to ensure that, number one, you're asking the question about suicide, but then secondly, that you have an assessment tool and ways to follow up risk when things are identified as higher risk. So how do you do that? Some of the key points outlined by Zero Suicide are being able to make sure that all your staff are trained. So training is usually staff specific, and the recommendation is that every single person that would come in contact with any patient or peer that you have would be able to be trained in an appropriate level of support so that they can help identify and ask important questions based on the level of their expertise about suicide risk, and then also know what to do with the findings of that risk. At our facility, we use Columbia Suicide Severity Rating Scale built into our EHR as a tool to help us let us do a screening to look for risk. It's very predictive of suicide risk, but can have a lot of false positives too because it's not quite as specific. The way that this tool is set, this is not the only tool you can use. There are many others, and when I end at the end, I will give you some references to websites that have toolkits that have multiple other evidence-based tools that you could use for screening. This just happens to be the one that we use. If someone is identified at high risk, it's very important then the next step in your crisis system has some type of assessment formulation for being able to do further levels of suicide risk. So it really would depend on your crisis system's level of support and the type of staffing patterns that you had as to what your roles might be for making decisions on where that person's outcome could go from there. At our facilities, we have both locked and unlocked facilities, and in the majority of cases, we have the support structures in place so that if someone is positive for screening, there is a system in place, a standard operating procedure of how we move forward with going into assessing these different risk factors. If you look at this diagram, the categories on the left really focus on the types of information that you want to get out once someone is deemed as a higher risk to gather the information that you need to help make decisions. And then the risk status, the risk state, what kind of coping resources and protective factors the person has, as well as triggers that they may face out in the community, help come together to create a risk formulation that can help dictate what level of care and support they may need. Communication systems are extremely important in this whole process of screening and assessment tools. All your staff needs to have a voice and be valued in their voice to be able to speak up for safety issues or concerns. When someone is deemed to be a higher risk, at our facility, we have different electronic principles in place as a system to help make sure that we don't have lapses in communication. So this picture on the left is of our electronic bedboard that basically, when we have someone that is considered like an immediate imminent danger, their name may be in bold or in a different color depending on the software that you have. And there's alerts that go up in our EMR system that basically let anyone that goes into that person's chart that's working with that person will have an alert that that person is considered a higher risk. Centerstone in Nashville, Tennessee does a great job of, when you look at their programming, and I think that is linked as well as a resource on the Zero Suicide website, to watch how they track and support transitions from different levels of care within their programming to make sure that the communication about suicide risk goes forward. one of the things that's extremely helpful is having reporting systems, electronic reporting systems that will allow you to be able to track that if you do a positive screening, that then that person transfers to get the appropriate risk assessment. And then if that risk assessment indicates certain outcomes, that then follow-ups like safety plans are done. And that you're able to have a system that decreases the chance that someone comes in, reports a high risk of suicide, and then doesn't have that addressed. Because that's easy to happen when you're working in 24/7 crisis and people change in different shifts and things like that. So we have rules of checking in with the team at every shift, where we're constantly working with that alert in our EMR so that we're documenting status and communicating with each other in our different levels of disciplines about what we're doing together to work with that, and have group huddles to talk about situations if people need certain levels of support. So key point number 2 is the actual concept of direct treatment and follow-up, meaning that we're going to be focusing on treating suicide directly with specific evidence-based treatments, and then working on follow-up plans, as we know that the highest risk is when the person will be leaving our crisis setting and then going back out into the community. So despite clear messages of efficiency and universal interventions and the support needed at discharge from crisis situations, we know, and we know these things work when you do them, but based on usual care in the US, actually only half of people who got crisis care get connected to an outpatient appointment during the first week. And a third in the US have no follow-up in the first month. And to know that this process works and that that's what happens in our overall system across the country is very disturbing. I'll give you another comparison story to another medical problem, a Lancet 2015 study with where they noted and evaluated the comparison of suicide and psychosocial therapies that they know decrease risk of suicide to treatment with statins for high cholesterol in relation to heart disease. One fatal heart attack is prevented for every 83 people on statins, yet one self-harm attempt is stopped for every 44 people treated with psychosocial treatment. So you have a more effective and a more cost-efficient treatment if we just instill it and utilize it. In terms of direct treatment and follow-up, I want you to think about 3 basic principles as a way of how to accomplish this within your organization. Number 1, and so important, is engagement. That means the team working together in a collaboration approach with the people that you're serving, so that we're going to be serving them with empathy and a genuine desire and connection. We're going to try to understand their ambivalence about death and the desire to die, to end pain, to end being a burden, the feeling of being a burden. We're going to work on creating hope and confidence, and that there's an alternative to dealing with this pain and suicide. And then we're going to make sure, and this is the most important one that I see happening sometimes in certain models of crisis care, is to make sure that that person doesn't feel that we're going through this information as a checklist so that we can mark off that we did what we were supposed to do, and rather that it's an exploration together with that person in a collaborative way to work on being able to understand where they are, what's going on, what works for them, and what roles and things that they think can help them have less suicide risk. My favorite question to ask in direct treatment is, what would be the one thing that would help you feel less suicidal? And I really encourage that type of approach to the way of doing this. In terms of evidence-based treatments, there are several. Listed on Zero Suicide, they kind of categorize them in 3 types that you could consider. One is a non-demand caring contact, which would be something that didn't require actual participation by the person that you're working with, but rather things like caring cards that you're using in between contacts to let them know that you're thinking about them. There's some great examples that you can actually download and use on the Zero Suicide website. There's a second type of evidence-based treatment is structured problem-solving therapy. So things like dialectical behavior therapy, DBT, or cognitive behavioral therapy for suicide prevention offer definite tools that you can use and have training in that have shown evidence to decrease suicidal risk. And then finally, a third type is called collaborative assistance and treatment planning. One of the most famous models of that would be CAMS, or Collaborative Assessment of Minimizing Suicidality, which creates a framework that basically does help support that engagement role through the process of identifying risk and then managing forward, and can incorporate multiple different types of clinical skills as you move forward. And there's strengths and different traits of each of these types of treatments, but there's a lot of information on how to utilize them and incorporate them on the Zero Suicide website. But if you are going to be doing direct treatment in your crisis center for folks who have suicide risk, I encourage you to look at these evidence-based treatments and look at how you can incorporate them into your workflow. And then the final piece of this second part is direct treatment and the follow-up piece. So the follow-up piece is so important because that is the highest risk period. It's actually, most things happen outside of the crisis center. And so when we're looking at the transition, we want to make sure that we work with direct follow-up plans that help us connect people to next levels of care and have a good sense of how they're going to do that. So this is just a picture to kind of help support the idea of making sure that we're connecting with people and talk with them about what matters to them in relation to suicide. This is an example of a workflow that we use in our playbook with our company to try to help show the flow from the time our peer welcomes someone when they walk in the door all the way through to when a provider may do a medical or psychiatric eval, and in red are the notification things that of the types of steps, such as the Columbia, which is in that triage section, and other types of things that we concern about. And you don't need to look at all the details. It's just the fact that we have a system in place that tracks and supports the different stages when we're working with someone that presents to one of our centers, with also recommendations about types of engagement tools to be thinking about as we go through those different phases. In terms of the direct care and follow-up plans, there's so many cool ideas and things that you can incorporate that are supported in the Zero Suicide website in terms of things that we've discussed. And I know from my experience at some of the crisis alternative conferences that these are some of the ones that have already been mentioned and are out there and being used, but it's great to think about how you can do this to have a warm handoff in that transition. It can be things like phone calls. So it could be your site calling the person in between the time that they have their next follow-up or next outpatient care on a daily basis or a 72-hour basis, depending on what risk concerns that you have. Another way you use phone calls is to actually have phone calls set up by having a connection in your community to your outpatient referral sources and have them speak with the people that they're going to be seeing while they're staying with you before they leave to help create that connection before they leave. Peer bridgers, so peer coaches with the specific goal of helping people once they leave a crisis facility get connected to their next steps can be another great way to help improve that connection and that support into the next follow-up phases of transition. Postcards, as I mentioned before, are another good example that have been shown to really improve the feeling of well-being and connection and support the decrease of suicide risk. And again, like I said, there are ones that you can print out and use off of the Zero Suicide website. I'm a big fan of the Now Matters Now website, nowmattersnow.org, I think, and it's not nowmattersnow.com. I think it's nowmattersnow.org that Dr. Ursula Whiteside has created, that has videos that share brief coping skills and distractions techniques and skills related to DBT techniques that people can use and access if they have internet as a way on their own to have a connection to some tools that they can use. And then finally, involving as part of the follow-up plan that person's supports and connections, whether it's family or community supports, and how are they going to utilize them as a support moving forward. Third phase and key point in the Zero Suicide system is having a formalized crisis and safety plan system for people that need it. Designing these has showed a 45% reduction in suicide behavior. And there's three kind of principles. One is picking the tool that you want to use. At RI, we're going to be using the Brown Stanley Safety Plan. If you look at it, it kind of reminds me in some ways of a wellness recovery and action plan geared for suicide risk. So it lets the person talk about what are their particular signs and things that they experience. It helps them focus on developing some brief coping skills and interactions of things that they can do. It gives them time to prompt and think about people and environments that work for them when they leave, that they can access and use, and people they can contact for help when they are in crisis. And finally, down at the bottom, helps prompt the work on decreasing means of access, which again is an important piece of follow-up plans, is definitely having a system in place that does not let you miss working on reducing means to access before a person would leave your crisis site if they've identified themselves as higher risk. And then finally, communication. As a crisis site, being a part of your community, I think it's really important to not just be serving the people that you see, but also be a very much an interconnection in your community and the work that you do, so that you know those next steps that people are going to be encountering and can work with them to think ahead and encourage them to have an expectation and knowing what types of supports are going to be out there, and incorporate that into their safety plan. That could be something that could be supportive or potentially a trigger for them if you're aware of different dynamics, and help them walk through what their next steps are going to be. So at RI, in our way of trying to be able to help make sure that we are taking into account being able to implement these three major steps, I think we've formulated it and run through it by a playbook. This playbook is going to help us to guide and help everyone know what their role is and what we do and how we're going to work towards applying these principles. In terms of our culture, kind of copycat after Disney's, but with our own focus. Some things are alike, and that safety is always first, and that's one of the 4 guiding principles that they use in their massive playbook they have. They always refer back to these 4 cultures for them, and we likewise do the same thing. So safety being first, a recovery focus second, meaning that we're always going to be working on trying to help that person have the say-so and meet them where they are in regards to the way that we're approaching this. And then best quality would be the tools, systems, technology, operations, and processes that we develop to minimize the risk of error as we go forward in doing that. And then having those engaged teamwork supporting all of these efforts is what really makes it go. So in terms of safety first, some additional things that I'd like that you can be thinking about that can tie into how you implement zero suicide, or things that we are incorporating into what we do, is in terms of data processing and quality improvement measures, having a peer safety committee, which would be peers in your company that work in a review in a non-judgmental approach of evaluating incidents and things that happen to be able to process and look at quality improvement measures that could be established and take place based on situations that you run into. Six Sigma principles, which is taking an industry measure of creating systems that minimize the chance of making errors, doing environmental surveys, which would basically empower all staff members to know and be able to walk around the environment of our crisis facilities, looking for concerns or problems that could be attributed to increased risk or danger for people that are there, as well as things that are happening in the environment. And then finally, employee surveys about their feeling of safety, and letting them have voice and being able to share ideas and things that can improve the whole overall company approach to it. What we call the fusion model is kind of pulling together elements of the medical model, classic hospital medical model, as well as the recovery model into a combination that we call the fusion model. And in doing that, in the context of zero suicide, I think some of these key phrases like connecting the person as a human, making sure that we're focusing on their empowerment and looking at their strengths, giving people choice, making sure that we're doing things with them and not to them in the process of this evaluation, being a part of the community in the recovery focus as a crisis center, and then obviously being inclusive for all. And then finally, in Be Best, Playbooks and quality systems help define roles. They help you collect data, which is very important. In the suicide field, some of the greatest advances have been in companies and organizations that have been able to have an ability to collect data about how they're doing in regards to the systems that they're using, to measure that data, and then manage quality improvement measures based on the results that they're getting. So I'd like to take a break before I close with this story about one of the organizations to see if there are any comments, Carrie, that we would like to talk about.
I don't see any comments in the chat box. Folks, if you have any comments or questions, please post them to the chat box. We did have a question come up before, though, about how do you make this cultural change from the old way of handling suicide to the new zero suicide?
That's a great question. I think just if you take examples of other agencies that have done that related to suicide risk, as well as other agencies, as we discussed, like the aviation industry, the first step was a declaration and a change in culture. I'm going to be talking in just a minute about Henry Ford Health Center and their approach and the results, astounding results that they had. When Zero Suicide went to discuss and investigate what were the tools that they used, the number one finding that they walked away with when you read about it was just how important the overall culture decision to say we are not going to tolerate suicide. We're going to aggressively change our whole culture so that the whole staff from top to bottom is focused on using these tools and using these systems and having that as a daily part of how we work together. So to me, I think the most important thing is a culture of leadership change. And if you go to Zero Suicide website, one of the tools that they offer at the very beginning of a decision to embark on this is an assessment tool of your organization that you can download and use to be able to evaluate where you are in all these different levels of leadership, culture, how much you're trained, how well trained your staff is, and their awareness of suicide treatments and suicidal information in the organization. So there's multiple. Really, yes.
That's I didn't mean to interrupt you. That's really helpful, because I think there's a lot of education that happens when you're launching Zero Suicide to break through those myths about that asking will somehow make someone think of suicide and that kind of thing.
Oh yes, and actually there is a fantastic section on one of those on the Zero Suicide website that describes and actually categorizes some of the most common suicide myths and the facts about them. That's another handy thing that you can definitely use in staff trainings and in the connectivity of understanding of those things.
Excellent.
I would love any feedback. Oh, yes. Mm-hmm.
We had a question from Teresa. What are your thoughts on clients having access to sharp kitchen tools in a crisis residential setting?
Okay. Now this is a good one. My thoughts are mixed on that. And I will talk about this, and it's a great part of this discussion, especially in our crisis alternative solutions world, where there can be differing approaches to the evaluation of how much the balance always between person-centered and freedom and having choice, which is so important to the personal patient experience that they have, versus safety. And the pendulum can swing different ways. You have an incident that happens, and liability concerns and the things that, looking back on a situation and what could have been done differently to prevent it, can definitely create sometimes an overemphasis, I think, on being so restrictive that you're losing touch with the experience of the person that you're working with. I think what we recommend, and I'll go back to this, if I can make this go back to the Disney slide that I was showing you that has that circle, is that at our site, we're going to always try to focus on the recovery focus first and give the person choices in everything that they can have choices in, as long as it doesn't affect their immediate safety of themselves or others. So part of that is in your screening and assessment process when people are coming in, trying to get an accurate assessment of where that person is in terms of risk. If someone is in the crisis residential program that would, say, be an unlocked unit, you would assume that you feel safe enough about them being in that setting to not have an immediate threat of trying to harm themselves in that immediate moment. I mean, they are not actively looking for ways to harm themselves in the immediate moment and have some kind of engagement and desire to work on their treatment. Those cases when you do have that rare, the more higher acuity folks who are in imminent threat and are not in touch with wanting to do anything but act on that, is where having a balance of still giving them choices in some things, the type of food that they want to eat, where they want to sit during the day, things they'd like to talk about, what they'd like to work on. But you may have them, if there's a high enough concern, you may also be making sure that there's no places that are anti-ligature, that they're in plain view of sight at that time by staff, to basically to help keep them safe until they're in a better place and have more hope and confidence in working in a different direction. So it's always a balance. And because when you lean in for mechanisms to increase safety, it automatically decreases personal freedom. And so it's always a balancing act of figuring that out. And you have to use the assessment skills that you have and the tools that you're using to try to delineate when it's necessary to intervene from overriding someone's personal choices because of safety concerns. Does that answer make sense?
That really does. I think that's really good. It's so person-centered. It's trauma-informed. It instead of having universal rules that apply to everyone, which may tend to alienate clients, it really helps them reach out. And I think the use of peers in this can be very, very helpful. We have another question. This one is from Susie. How do you address it when clients say that they're not feeling suicidal anymore just to get out of treatment?
Well, I think so. It depends on if you're looking at the process. If you have instituted in both a screening tool and an assessment tool, most of your assessment tools, if done in that collaborative format that we discussed, are going to help you connect with that person and have a better chance of them being real and talking about what they're really feeling. So sometimes we may have someone come into our site that has been used in their community to being able to feel like they weren't going to get help unless they threatened that they were suicidal, but they really have other things that they're seeking and they don't really have an intent or a plan to harm themselves. And so when they come in, the screening test might be positive for all 6 questions on the Columbia. But then when we actually do the assessment and are talking to them, and they realize that we're not trying to kick them out of support and care, that we want to help them work forward on moving forward in their recovery goals, they can open up and say, you know, that's not really the case. So that's one way that happens. And the other angle would be someone who really is a higher risk, who is now changing their story from what they originally presented. And that's where, when you go into depth with those assessment tools and try to gather all that information, I think it becomes harder to not show your hand, so to speak, in terms of it's easier to see when people are minimizing symptoms because they're not participating or giving full answers on all the original things, because you usually have some type of background information from the screening and from the initial presentation that leads into that. So if that could be a warning sign for me if someone is not, if I'm coming with them in a helpful, collaborative way, and they're not willing to talk to me frankly about what they're feeling and what's going on, even though that my intent is there to help them and be collaborative, that's a concern and a risk factor for me. So I may put that into an arena where if I just didn't feel like I felt good about their safety based on what they were telling me, that I may want to observe them a little bit longer and try to work with them and engaging more about understanding what would the kinds of information that would help us feel safer about working on their plan so that they can get out of the least restrictive care as possible. That's one other term I didn't mention in the recovery focus, is one of the great parts about crisis alternative solutions, and it's such a recovery focused thing, is decreasing and minimizing the amount of restriction that one needs for the level of care that they present. And so having these tools in place can really help you better align the appropriate services so that we're given support and engagement and connection with the least amount of restriction to their freedom.
That's really helpful. I think that's a really important message. What we have also noticed is that the more involved peers are and the more involved we are in establishing a culture that permits people to talk about suicidal ideation, the less likely they are to feel like they have to say one thing to get sent home. We really need to see that improvement in all other ways in order to feel comfortable about them working to on their safety plan to go home. But with peers, often they can be very real with people in a way that that clinicians might not be able to be. And so when you have peers involved, they can help just get down to the nitty-gritty and help the individual be honest with themselves as well as us.
Agreed. I don't know of no better tool to increase your ability to engage as a team is to have that voice and that part of the support and engagement and empowerment that peer coaches offer in our crisis world. So I'm very supportive of that and I assume that the majority of the folks in our crisis alternative group have that service, but if you don't, I definitely would encourage looking into it. Now, any other questions, Carrie, or in the last few minutes, can I close?
We have one last question,
okay.
Short one. How do you cope? How do you deal with like a one-size-fit-all intervention?
Can I get a little more detail about what that question means?
Well, it might be a rule for all clients, no smoking, something like that. I think that's what the person posting the chat was interested in. Are there ways to apply like a no smoking rule that could be helpful in terms of establishing zero suicide? Without, I'm thinking, person is thinking that a one-size-fits-all intervention may make the client feel not represented. It's kind of like having a rule.
Yes.
Specific.
Totally agree. And I'm giving you guidelines and a system in place that is very checklist oriented in terms of the tools you use. I think that but I do think there's a way to have a fusion, as I mentioned before, in terms of balancing this medical model versus recovery model, to have a fusion of making sure that you go through appropriate risk screening and risk assessment tools that then can help guide individualized approaches in the way that you support and work with that person collaboratively and what their needs are. And like I've said before, any kind of rule that's for everyone has the pros and cons of, every time that you don't have individual choice, you're having some form of restriction. But yet the reality is probably most places have some formats where they do encroach on personal choice. And so it's trying to help make sure that you give persons as much that balance based on the type of service that you're providing, to be thinking about the balance, and always from a staffing perspective, work collaboratively as teams to think of ways to maximize personal freedom and personal choice while keeping people safe.
Sounds
I wish
great.
I had more definite, but I think that theme is really important, and probably one of the next steps is continuing to open up as crisis access opens up to the rest of the country, to develop even further standards and practices, just as some of these other organizations have done, that help share what works and what doesn't work in that arena.
Sounds good. I think we can move
and then
on.
I saw one other question that asked about how do you engage your teams?
Right.
That flashed up on the chat. And the last thing I'll say about that is, when you look at organizations that are successful in this, engaging teams, when we think about engagement, we think about three things that you need in your company to be able to do that. So one is that you give people voice, so that all staff members have a voice and an input to be able to say, these things are working, these things aren't working, I have concerns about this, I really like this. Second, that they have value, that when a staff member is making some great things happen on the floor in terms of engagement, that a leader can go over and give them whatever matters to them in terms of the value and gratitude that is meaningful to them, and for leaders to be aware of those kinds of things, and to be able to show value as a company to your staff about engaging in the missions that you're doing. And then finally, vision. And so that's where we talk about the playbook creates an understanding of what the roles are, what the systems are, and that your training revolves around supporting that. In the airline industry, one of the things that they do is they train together as teams. So they don't separate out the different disciplines. They train, a lot of times they do a lot of their training from a safety perspective as teamwork, so that they go ahead and get instilled in that teamwork, collaboration, engagement motif, so to speak.
That's great. Okay, let's hear your story.
In closing, I'd like to tell you one last story about a system that has done this successfully and really drove some of the future of zero suicide work. So back in the late 90s, Dr. Ed Coffey and staff there were taking a look at their numbers at their Henry Ford Medical Group. And if you look at those numbers in 1999, their HMO is in red. So they were averaging about 110 suicides per 100,000 people in their network, versus the general population of Michigan was down at probably in the 10 per 100,000 of Michigan general population. So you're seeing a factor of 10 times higher levels of suicide in their system. And they began a process of changing this system. And you can see they already started lowering the numbers even in 2000 and 2001. But they launched something titled the Perfect Depression Care Initiative in 2001. And it, again, like I mentioned before in the earlier comment, it really focused on a culture change of zero deaths as the foundation of the initiative. And they worked on developing care pathways to assess and modify suicide risk for patients in their system who had depression. That was their focus of their initiative. It was very focused on being proactive versus reactive in the tools and the things that they used. And some of the results were that they actually, in the year of 2009, 2009 had 0 deaths. And in the time period of 2009 to 2010 had 18 months of that total period with 0 suicides. And overall, even when they did have some slight upticks in variance over the course of years, they're markedly lower, have never gotten back up to the numbers of where they were when they started this project. And this became a foundation of taking a look of the fact that you could do this, and that you could attack and aim for 0 suicides and implement these systems and have success with it. And others have replicated success, as was shown in that video. And I mentioned, one of the leaders in zero suicide principles being Centerstone in Tennessee. So in closing, in the 70s, in the aviation world, safety planning adopted a culture to stop all human errors that were resulting in accidents with great success. And we now have a similar pathway in behavioral health care that we can embrace. So adding like screening and assessment tools, direct treatment and follow-up for suicide, and a collaborative safety planning is kind of 3 major system changes that you can support, it can help along with this culture change for you and your organizations to embrace zero suicide and have success with just creating a safer environment in terms of suicide risk for the people that you come in touch with your crisis services. So I encourage all of you to go to these websites. One would be zerosuicide.org, which basically is a summary of a lot of the top things I've been discussing, with lots of links to thought leaders, publications, summits that are available to talk about it, some of the videos. That Now Matters Now is a picture of Ursula and the work that she does that I described earlier. And it links and is connected with the Zero Suicide SPRC.org board, which goes into even more depth. And this is the website that has the combination of a lot of these different care cards, tools that Centerstone uses, tools that, in terms of different assessment tools, screening tools that you can use, safety planning tools, a lot of great information there, as well as the toolkit to help assess where your company is, how to instill leadership culture and to work on those things. So I encourage you to check those out and take some steps towards looking what you can do within your organization to adopt these things and aim for zero suicide. Thank you.
I would really like to thank Dr. Browning for sharing his inspirational message. We can really make a difference and save lives. Thanks to all of you, and we hope you join the Crisis Residential Association. Thank you.